Okay, a major depressive episode is characterized with more than or equal to 2 weeks of depressed mood, anhedonia, sleep disturbances, guilt, impaired energy, motivation, and concentration. When it comes to choosing the correct antidepressant, there's no superior efficacy between one antidepressant and the other. So what you consider are the side effect profiles and other factors, including medical and psychiatric comorbidities of the patient. When it comes to buproprion, a norepinephrine and dopamine reuptake inhibitor, it has mild stimulant effects, so patients who need increased wakefulness, more energy, and concentration, it can be very helpful. If patients smoke, buproprion is an excellent choice, and it can even help with weight loss. Another big thing is that it does not cause sexual side effects. So when do you not give buproprion? You do not give buproprion if the patient has a history of seizures or eating disorders. Let's talk about TCAs. So TCAs are actually like third or fourth line therapy for major depressive disorder. Really, we use this for neuropathic pain, for patients with peripheral neuropathy or diabetic neuropathy, even post-herpetic neuralgia. Sometimes you can see it even in migraine prophylaxis, but a big reason why we do not give TCAs for major depressive disorder, at least as a first-line option, is because it causes arrhythmias. It inhibits the sodium channels inside the myocardium, and this leads to prolonged QT intervals. And if you have a prolonged QT intervals, leads to torsade de pointe and wide QRS complexes. And another big side effect of TCAs are anticholinergic side effects such as tachycardia and arrhythmias. They can cause hypotension. You can even experience CNS symptoms such as confusion and hallucinations. On top of that, you can have intestinal ileus, even constipation, and urinary retention when it comes to the GU system. Mirtazipine is an antidepressant with serotonergic and noradrenergic activity. However, it can be very sedating and it causes increases in appetite. You also don't use MAOIs for first-line treatment for major depressive disorder. These can cause weight gain. On top of that, very, very lethal side effects such as hypertensive crisis and serotonin syndrome. It is used, however, in atypical depression. So if patients have hyperphagia, hypersomnia, or leaden paralysis, or rejection sensitivity. Hyperphagia is an increased desire for food. Hypersomnia is increased sleepiness, even if you just slept for 7 hours. And leaden paralysis is when patients say that their muscles feel fatigued as if they are weighed down with lead.